and what may be considered an issue. It's important that we're aware of cultural and social expectations, as those are going to impact parents' expectations of their children. It's also important to identify that if a parent feels that there is an issue, that we offer more than assurances. As this alone will not ease their concerns, it's important for us to educate and incorporate developmental processes with this education. In our role, we're going to be conducting an accurate assessment. We're going to be anticipating concerns that the parent has, and also help them to understand what healthy bowel and bladder function is, as parents themselves may not have good bowel and bladder function. If at any time there's an issue that is complicated, out of normal developmental range, or is causing significant distress for the parent and or the child, then those are something that is important to refer for. So we're going to go over briefly a little bit of some normal patterns of elimination, and these are probably very common for you. But in infants, for bowel patterns, we know that they're related to the amount of the feeding and the frequency of the feeding, and that there are differences between formula-fed stools and breastfed stools. In breastfed babies, they may have many small stools per day in the first week, and then it'll decrease to anywhere from 1 to 6 stools per day. Breast babies' stools are typically soft and a light yellow and a sticky consistency. If a breastfed baby is having less frequent stools but is growing and thriving and not appearing to have any issues in their tummy, then that is not a problem. Formula-fed babies can have anywhere from 2 to 4 stools a day in the first month. They can be firmer, darker in a brownish greenish tone, or even a dark yellow. Both breast and bottle-fed babies, as they are introduced to more foods, their stools should become a little firmer and a little darker, but it's important that they stay soft and it's easy for a little one to pass. It's also important to educate parents that the consistency of the stool that it is passed is what determines constipation, not necessarily the effort, as grunting and straining can be normal. Urination for infants is based on the volume of fluid that they've taken in, and typically should be at least 6 wet diapers a day. Let me back up on that. They should urinate at least 6 times a day. But they can void small amounts, anywhere from 15 to 20 times a day. The urine should be pale yellow or colorless. Voluntary bowel and bladder control is dependent on the myelination of the pyramidal tracts in the spinal column, and those are usually the most approaching development in 12 to 18 months. Parents may start noting that anywhere from 9 to 12 months that their little one is having more regular patterns. They may notice that they have a BM after feeding or first thing in the morning, or that they stay dry several hours in the day, or urinate after waking up from a nap. Many parents may take this time to work with older infants, but this is not toilet training. This is just being associated cues for needing to go potty. Let's talk a little bit about normal patterns for bowel and bladder for toddlers and preschoolers. Their patterns are usually fairly regular, 1 to 3 stools per day, and typically 5 to 7 times per week. Normal stools will have an odor, and they should be slender and light to medium brown. They should be soft and easily passed by the child. By the time the child is 2, their renal function is fully developed. Their output is influenced by the amount that they take in. It is also dependent on the environment, if they have been outside sweating a lot, if they've been sick, if they've had a fever, if they've had any diarrhea. They will typically urinate anywhere from 8 to 14 times per day. And the rule of thumb is that their necessary intake should be start with 30 milliliters of a fluid per kilogram per day of water. And just to note, if a parent has issues or concerns that a child is not sleeping through the night, there's really no need to treat unless they're greater than 5 years old. So, a little bit on school age children. Their bowel patterns by the time they're in school are very similar to those of an adult. They should be toilet trained by the time that they enter school, but soiling may occur occasionally, and that could be due to poor hygiene or because the child didn't respond quick enough to a bathroom need. With school aged kids, it's important that they are offered independence and privacy when going to the bathroom. At this age, they are going to urinate anywhere from 6 to 8 times a day. You would evaluate for any dysfunctional avoiding if they're having incontinence during the day or issues with bedwetting at nighttime. After evaluation, those may need a referral. In adolescence, bowel and bladder patterns are, as adults, there can be some abnormal variations when there are eating disorders present. Adolescents who have high demands of their schedule, are stressed, have increased school requirements, or irregular eating patterns may have irregular bowel and bladder function. And then sexual activity can contribute to bowel or bladder functioning, including infections or constipation. So, assessment of elimination status begins with a thorough health history with questions being asked to the parent or the child depending on the child's age and ability. It is, though, important to speak with the child as the parent may not be as knowledgeable based on the age of the child of what their elimination patterns are. It's important to assess the frequency and the characteristics of urine and stool. How often is the child urinating per day, and how often is the child having a bowel movement? Also get some information about what the stool looks like, if it has a smell, its texture. It's important to assess where they have their bowel movement. Do they use a toilet for both urine and stool? And do older children have any aversions to using the bathroom at school? Ask that, are there any issues with the child, such as resisting going to the bathroom? Do they use any medications, including over-the-counter preparations or home remedies, to help facilitate a bowel movement? You need to ask a little bit more about habits and timing of the bowel movements per day. It's also important to be familiar with the names that the family uses for stool and urine and body parts and the process of going to the bathroom. In your review of systems, you're going to ask if there's been any history of constipation or diarrhea. It's also important to get the parent's definition of what constipation and diarrhea are. If they're having any of these issues, did they start after a particular incident? Had they been sick, an issue with toilet training, food, or a change in diet? It's also important to remember, though, that diarrhea can be a presenting symptom for constipation, as stool could leak around more solids, as liquid stool could leak around more solid stool. It's important to ask if there's been any history of urinary tract infection. Have they had any illnesses, injuries, or operations related to bowel or bladder? Does the child have any physical conditions or chronic illnesses that could affect going to the bathroom for stool or urine? Is there a history of bedwetting? And also what medications they're on, including any over-the-counter preparations, herbs, or complementary medications. Your health assessment is also going to include a family history. You're going to want to know if there are any environmental or psychosocial issues. It's important to assess the parent, if they how they feel about toiletering, if they have any issues with urination or defecation. How do they interact with a child as they're trying to go to the bathroom? It's important also to deal with any how they deal with any toileting accidents, such as bedwetting. Ask the parent what are their plans for managing toilet training. Talk with the parent about a typical diet for the child. And then it's important to assess the toileting facilities. The physical exam is going to include an external examination of the perineum, the anus, the urinary meatus. You're also going to look at the base of the spine. You're going to auscultate and palpate the abdomen for bowel sounds, softness, masses, peristalsis, and any tenderness. And then making sure that the gross motor neuro exam is age appropriate. Diagnostic tests that you might do based on symptoms and assessment include a urinalysis. You may do a stool specimen based on the symptoms. Diagnostic imaging would be as indicated, and that would be specific to the information that's in Chapter 33 and 35. So let's talk a little bit about toilet training, some management for normal patterns. In toddlers and preschoolers, we're usually seeing toilet training by the age of 4. Most children have successfully been trained between 2.5 years and 3.5 years of age. It's important to educate parents that successful toilet training requires being sensitive, understanding of the development and at the appropriate age of the child, good communication, having some humor, and being patient. During your visits for normal well baby visits, you can lay some groundwork that will help your parent to become more in tune to this. Introduce the topic at the 9-month visit, and then you can revisit it again at 12, 15, and 18 months. You're going to be assessing for any cues that the baby has. You're wanting to assess for parental readiness, their expectations, what their plans are. You're looking for physiological readiness by the age of 18 months. And then also you're looking for psychological and social development at 24 months. As the voluntary sphincter is not typically in control until about this age. Table 12.2 shows a great guideline for assessing toilet training and readiness, and it includes both the child's skill type and then how that will reflect in toilet training. It's also important that the parent be able to communicate with the child that the goal of using the toilet is not to hold in urine or stool. As we talked about, it's important to review kind of the timeline of when a little one is developmentally ready to start toilet training, because starting too early can cause dysfunction within the family. It's important also, though, to know the culture of the family that you're working with, as some cultures start training at a much earlier age than others do. There is a pattern that is seen. You will see nocturnal bowel control first, then daytime bowel control, then daytime bladder control, and then nighttime bladder control is how it will progress. And if you're seeing a little one who is resisting being trained, then it's better to stop, wait a couple of weeks, and resume then and see how receptive they are to toilet training. Let's talk a little bit about bowel and bladder dysfunction. This is when a child may actively try to prevent elimination. This could happen if there's restricted access to the facilities, if a child has had a painful bowel movement and therefore doesn't want to hurt and tries not to go to the bathroom, have a bowel movement again, or if they're playing and they're too busy to go. Urinary frequency, urgency, and incontinence are very common in bowel and bladder dysfunction. Persistent problems with incomplete emptying of the bladder can lead to UTIs, vesicoureteral reflux, and in severe or long-term situations could lead to renal damage. If the child is constipated and is having a full colon, that can exacerbate bladder dysfunction by applying pressure to the bladder wall or restricting urinary flow. And the child who is having issues with bowel and bladder dysfunction may experience stool incontinence or encopresis, either with or without constipation. So let's talk a little bit about encopresis, which is fecal incontinence when bowel control is expected. There are a couple of different types. Primary encopresis is a child who has never been toilet trained. Secondary or discontinuous encopresis is seen in those children who've previously been trained who, but for whatever reason, are now beginning to have issues with soiling. There are two subtypes: encopresis with constipation, which is associated with stool retention, constipation, and incontinence overflow, and then encopresis without constipation or a functional non-retentive fecal incontinence, which is less common. Encopresis may be more common than believed because families may not wish to inform the caregiver, the healthcare provider, if there's any issues, as there may be a social perception applied to it. The cause may be unclear, but there can be physiological and psychological factors involved. Often there's a history of an acute stool problem that's just not adequately managed. These kids get into a cycle where they're constipated, then they have a painful stool, then they're going to hold the stool in, which leads to more severe constipation, more pain, and more retention. This also leads to distension of the colon. You can have stretching of the rectum, peristalsis is impacted, and you can have a decreased sensory threshold in the rectum and weakened rectal and sphincter muscles. The stool becomes very dry and hard and difficult to evacuate, and therefore you can have some soft, semi-formed stool that passes around it from higher in the colon. Some physiological factors associated with this condition are inadequate fluid intake, dehydration from illness or perspiration, change in diet, and they're not getting enough fiber from fruits and vegetables. And then there can also be secondary retention, which causes pain, anal fissures, neurogenic conditions can lead to this, endocrine and metabolic issues, and the medications. You may note that the encopresis may occur if there's been a major family or life adjustment. Could there have been a divorce or a death in the family? If there's been inappropriate toilet training. You could see it if there's been irregular toilet patterns, such as being caused by traveling unfamiliar environment or an unpleasant bathroom. Lack of regular routine as well. Other psychosocial factors may include physical or sexual abuse, and then behavioral issues for those children who do not want to stop an activity to go to the bathroom. On your clinical findings and your history, you may have reported soiling, decreased bowel movements, large or painful stools, bloating or abdominal pain. There may be bedwetting or UTIs. There could be decrease in appetite with weight loss. On physical exam, you could have some overflow, soiling, abdominal distension, tenderness. You may even be able to feel firmness in the abdomen that could possibly be hard stool. There may be anal fissures. You could notice a sacral dimple or a hair tuft, or possibly some other neurological signs. This could include some absence or decreased reflexes, such as abdominal cremasteric or an anal wink reflexes, and you could note even deep tendon reflexes. These may indicate a neurological component. The diagnostic study that you would do to identify the causes of constipation would be a flat plate, a KUB of the abdomen. Some other differential diagnoses to include would be an anorectal stenosis, spina bifida, or a spinal cord dysplasia, Hirschsprung's disease, mental retardation, hypothyroidism, hypercalcemia, CP, or other organic causes, possibly cystic fibrosis. Management of constipation includes establishing a regular bowel pattern. It's important to demystify the problem and not to blame anyone. To help with bowel evacuation, Miralax, polyethylene glycol, can be used, and this is found to be as effective as enemas but less traumatic to patient and family. It's important to work on bowel retraining and to establish a regular pattern. Once that retraining has occurred, then ongoing maintenance, including good fluids, fiber, increased activity are important. Be sure and look at the table in the chapter for management of children with encopresis with constipation. It talks about the different treatment phases and medications that can be used to help with management of the condition. And it's also important that once they're in a maintenance phase, that medications are used for a minimum of 2 months and for at least 1 month after resolution of all the symptoms. Some complications that you may see related to the constipation is being ridiculed or shamed by their peers, and then having intractable constipation because they've developed a megacolon from holding in the stool. And so education for the patient and the family is best. Encourage prevention, and then maintenance, and then if there's any reoccurrence, to get on that sooner rather than later and trying to maintain that healthy bowel pattern. Before we close out this segment on this chapter, let's talk about stool toileting refusal, and that's when the child uses the toilet to urinate but refuses to use it for a bowel movement. They would defecate in a diaper or pull-up. It's important to do a good history, and your parent may tell you that they have good bladder control but refuse to have a BM on the toilet. They may have regular or irregular bowel patterns. There are consistent signs from the child that a bowel movement is imminent, but they may go and hide, and the physical exam may be unremarkable. Other differential diagnosis of this would be constipation or encopresis. Management of this condition would be to return to diapers and reintroduce toilet training in about a month when the child is interested. Management of this condition is to be, very matter of fact, not to pass any blame. Offer the child time to sit on the toilet when they typically would have a bowel movement. Have the time sitting on the toilet being positive and fun, never forced. One key thing is never to flush the toilet with the child sitting on the toilet, as this may upset them. So if you have a child that does have a parent that has a child that suffers from this, you may encourage them to bring sticky notes with them if they're out in public, because once you have that change in position, the toilet may flush in a public restroom, and part of this is to help the child not to traumatized with an automatic flushing. This also may be a time when incentives or positive feedbacks may be offered that may encourage the child, but express to the parent that excessive praise is not recommended. Okay, that's going to be the end of the stool part of this, and we'll come back and we'll talk about urination.